Good afternoon, everyone. In the spirit of truth and reconciliation, Parkinson Canada acknowledges that we are gathered today on the customary and traditional lands of the Indigenous peoples of these here territories. While we meet today virtually, I would like to take a moment to acknowledge the importance of the land which we each call home. I wish to acknowledge this land that I am on while we gather today. For thousands of years, it has been the traditional land of the Huron-Wendat, the Haudenosaunee, and most recently, the Mississaugas of the Credit First Nations. This land is governed by the Dish with One Spoon Covenant between the Haudenosaunee Confederacy and the Confederacy of Ojibwe and allied nations. This covenant is an agreement to share, work, and protect this land together in harmony. Today, this is the meeting place and still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and live on this land. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that call this country home. As we dive in this afternoon, I would first like to thank AbbVie for sponsoring the Advocacy Roundtables and for making all of this possible. I would also like to thank and welcome the regional community partner organizations who have participated in our roundtables. The Parkinson Society of British Columbia, Parkinson Association of Alberta, U-Turn Parkinson'S, Parkinson Society of Southwestern Ontario, Parkinson Quebec, and Parkinson Society of Newfoundland and Labrador. The engagement, insights, and collaboration have been invaluable and make us stronger together. Over the past 3 months, Parkinson Canada held 8 regional roundtables and concluded the series with a national roundtable held at the end of October. We brought together over 150 voices from the Canadian Parkinson's community who provided insight, clarity, and backing that will support our advocacy to government in the months and years ahead. Our Advocacy Roundtable series brought together thought leaders from across the country, including people with Parkinson's, care providers, healthcare professionals, and community organizations. Following each of the roundtables, our team debriefed and captured key themes from the regional session. While there were some unique concerns in different parts of the country, there was also a tremendous amount of consistency in the needs of people living with Parkinson's in Canada. We heard that the need for further training on Parkinson's for members of the Parkinson's healthcare teams are essential. The desire for care coordination and improved patient education in clinical settings is key, and the need for more movement disorder specialists across the country. We'll be discussing these 3 topics in more detail today, but first I'd like to set the stage. I'm going to present an overview to the Parkinson's landscape in Canada. Parkinson's is one of the fastest growing neurological conditions in the world, and Canada has one of the highest prevalence rates, with more cases per capita than many other countries. There are over 100,000 Canadians living with Parkinson's. That number will grow by 30 people tomorrow and the day after that. But rates of Parkinson's are also increasing. Within 10 years, we will go from 30 new diagnoses per day to 50. That will be 50 Canadians and their families receiving the life-altering news that they have Parkinson's. 1 in 5 people living with Parkinson's in Canada wait a year or more to receive a formal diagnosis after reporting their symptoms to a medical professional. Prolonged wait times to receive diagnosis have serious implications for an individual's quality of life, and it definitely increases the likelihood for both physical and mental health deterioration. In 2018, Parkinson Canada conducted an environmental scan to assess wait times to see a movement disorder specialist, and the average national wait time was 11 months, with some regions reporting wait times of more than 2 years. This is incredible. The numbers are inherently dynamic and are especially likely to have changed during COVID, not necessarily to the favor of people living with Parkinson's. It is estimated that there is only one movement disorder specialist for every 1,500 people living with Parkinson's across Canada. Most of these specialists are in major urban centers within the provinces, which again poses a geographical barrier for rural Canadians. There are no movement disorder specialists in PEI or in any of the territories. In the territories, there are also no general neurologists, which means that people who are living with Parkinson's have to travel to see neurologists or meet with a traveling neurologist who visit intermittently or have to attend appointments with clinicians in other provinces. These are some major barriers that need to be addressed. With that overview, I am glad to pass back to Amanda.
Thank you so much, Cameron. Well, I have the pleasure of introducing our first two speakers, Bob Kuhn and Joe Vancouverdin, who have been our Parkinson Advisory Council representatives throughout the series of roundtables. Bob has lived with Parkinson's for 15 years, recognizing the significant need for people with Parkinson's to have encouragement, information, support, and hope for the future. Bob joined the Parkinson Advisory Council. Bob has had a wide variety of experiences with charitable organizations in the area of Parkinson's. And in addition to his charitable work, Bob continues to practice as an attorney. Joe Vancouverdin lives in Peterborough, Ontario. He's retired and was diagnosed with Parkinson's 10 years ago while living in Northern Ontario. He is active with his local support group, an ambassador with the Davis Phinney Foundation in the US, and an active member of the Parkinson Advisory Council. He participated in all 10 roundtables this past summer. So welcome both Bob and Joe. Bob, I want to start with you. Can you please tell us a little bit more about the Parkinson Advisory Council?
Sure, and thank you for having me this afternoon. How can an organization, especially one with such an overwhelming mandate, understand and serve the needs of Canadians who grapple day to day with Parkinson's disease? The diversity of symptoms, complications, prognoses, and treatments of the disease are stunning, and it can easily be the case that an organization such as Parkinson Canada will get caught up in its priorities while forgetting its purposes and the people who have the biggest stake in the work. People with Parkinson's. Parkinson Canada realized the importance of its accountability to its purpose, its people with Parkinson's, and its priorities. The organization's establishment and achievement of its goals must reflect the heart of its constituents. All aspects of the work, including allocating resources, must be undertaken and measured in that context. This is where the Parkinson Advisory Council fits in. There are 12 members of the PAC representing a broad spectrum of diversity. They meet monthly and evaluate, coordinate, and carefully consider different aspects of the mission-based work of Parkinson Canada. And they report directly to the CEO. While the PAC is not part of the legal decision-making, it plays an important and very significant role and has an impact on virtually every aspect of Parkinson Canada work. It is the job of the PAC to ensure that the organization does not operate in a vacuum. And I see realistic opportunities ahead to collaborate with other organizations, which I hope will result in increased efficiency and effectiveness for all of those organizations and Parkinson Canada, and in turn benefit people with Parkinson's locally, provincially, federally, and even internationally.
Thank you, Bob. Over to you, Joe. Now that we all know a little bit more about the PAC, can you tell us how the PAC was involved in the process of the Roundtable series and what you learned from it?
Thanks for the introduction. When the plan for the roundtable discussions was brought to the PAC meeting for discussion, I thought this would be a great opportunity and volunteered to sit in on all 10 roundtables to really hear firsthand the differences and the similarities of services offered to PWPs across our country. It was great to have Bob jump on board as well, just to see if we could hear anything from our perspective as people with Parkinson's that could be recorded and help provide unique insight to Parkinson's Canada. What I heard was a reinforcement that this disease was, although similar in its foundation, provides a unique health challenge for all of us. And that challenge is then passed on to our healthcare professionals on how to treat us to maintain a reasonable level of comfort and quality of life. This is further complicated by our diversity, ethnically, geographically, and availability to get to a location for treatment. Those of us that enjoy modern technology through the internet have little idea how life can get complicated in areas void of service of even telephone or cell phone. Also, we hear from the care partners. Their burden may become exasperating as they and the patient loses the ability and motivation to effectively maintain both their best efforts to self-manage their health in the latter stages of this disease. As the distance grows between patients and available clinics, the need for self-management of our condition will become paramount to those furthest away. We'll need a support system that can be implemented with technology to meet the needs of dense clusters of PWPs in the urban areas, even to a paper system that can provide support for those isolated by distance, culture, or choice. Also, we heard the need to build in an emotional supportive system to bring empathy and mental health care to those that are suffering, confused, depressed, or struggling with their PD experience with apathy. Starting with our best practices, we'll need to look at others like Dr. Bloom in the Netherlands for some of their successes and treatment models and to create a system that will meet our needs in this vast country.
Thank you so much, Joe. And one last question for you, Bob. Can you share a little bit about your experience having attended all of the roundtable sessions? What was it like hearing people's stories about their interactions with the healthcare system in their areas while living with Parkinson's?
Yeah, after listening to the concerns and the feedback and the victories and the challenges and the frustrations that were expressed by those attending the roundtable discussions, I was struck by the diversity of the PD community in Canada. But it was so encouraging to hear all of the participants who were so committed to providing hope and improved service to members of the Parkinson's disease community in Canada. I was reminded of my grandmother. She died in her 90s some years ago, at least 2 or 3 of her children, including my father, suffered with Parkinson's disease. I thought of the quilts that she made for her large family of 15 children. She spent endless hours, often in less than ideal circumstances, producing a patchwork quilt that would provide a warm and comfortable protection from a Manitoba's cold winter. Sometimes women from the community would work together in a quilting bee at which they shared their skill with others. And we too are laboring on a patchwork quilt for Canadians suffering from Parkinson's disease. It's sometimes lonely and incredibly challenging work, but through these recent months of listening and engaging each other through the roundtable discussions, we are helping to better define and coordinate the patchwork quilt that is Parkinson's in Canada today. In seeking to communicate its commitment to resilience, adaptation, and perseverance, Parkinson Canada has adopted the phrase, "no matter what." This expression reflects a commitment to overcome obstacles and to provide support and service Canadians living with Parkinson's. We at the PAC will continue to learn about how we can work better together, refusing to give up the vision and insisting upon a better future.
Thank you so much, Bob and Joe, both for your support of the roundtables and also for continuing to be such active contributors to in our advocacy work. All right, so throughout the roundtable discussions, we heard about the need for better family physician and allied healthcare professional training on Parkinson's. Some attendees described circumstances where early symptoms of Parkinson's were not well recognized, leading to delays in diagnosis. From the perspective of allied healthcare professionals, we heard many stories describing the benefits of Parkinson's specific training. From one individual who found specialized exercise classes more beneficial as they targeted multiple symptoms of Parkinson's simultaneously, to a care partner whose father was experiencing weight loss due to Parkinson's and a high protein diet assigned by an unknowing dietitian who was just unaware of the implications for medication absorption. So here to speak to us about his personal experience and feedback on this topic is Bryce Perry. Bryce has a combined 30 years of experience of coaching, training, motivating, and leading people. He has worn many different hats, from a general manager of a Fortune 500 company, leading 300 employees, to founding and running a nonprofit corporation in both Canada and the US. He has had numerous radio and television appearances, is a published author, and has given keynote and motivational speeches to crowds of thousands. His desire and passion has always been to inspire and motivate people to live their best life. Then in 2012, at the age of 42, Bryce was diagnosed with Parkinson's. After a few years of adjusting to his new reality, he founded Doing Life Today. He now coaches people with Parkinson's, encouraging, motivating, and reminding them that a Parkinson's diagnosis is life-changing, but not a death sentence. Helping people to make some lifestyle changes and keeping them accountable to those changes, Bryce has seen many people thrive in life regardless of their disease. Welcome, Bryce, and over to you.
Thank you very much, Amanda. I appreciate that. So everybody knows that with Parkinson's, everybody's journey is unique, right? It's not a cookie cutter disease. People go through different things. But the one thing that I find very unique in all my discussions with everybody who has been diagnosed is the need and the lack of how long it took them to get a diagnosis and how they came upon that. So, what I'd like to do is I'll just share a little bit of my story, and you can take from it what you might need. But I'm 51 years old, so I was diagnosed with Parkinson's in 2012, so I was 42 years old. But my journey with Parkinson's started probably when I was about 39 or 40 years old. My grandmother had Parkinson's later in life, and eventually passed away. And as a matter of fact, the day that she passed away, the week after she passed away, I started getting a twitch in my right hand, and I was 39 years old, and I started getting this twitch, and thought that was kind of weird and interesting, but I just thought maybe I was just stressed out or having a rough time with things. And as time progressed, from about 40 years old, when I turned about 40, again, that hand twitching, then the stiffness was kicking in. And I was realizing that when I got out of bed in the morning, I was a 40-year-old getting out of bed, seeming like I was 7 years old and stiff and couldn't really move or get out of bed properly. So at that point, I thought I'd better go and get this checked out. And I went to my GP, my doctor, and kind of talked about some of the things that I was experiencing. At which point, he said, "Well, that's interesting and strange, but let's go get some tests done." So I did a battery of tests, blood tests, and different type of tests. And I know this isn't the right term for it, but they do. I think I called it shock therapy, where they're looking for carpal tunnel and different things like that, where they hook you up and they send shock system through your body, and CAT scans, everything else, you name it. After all that came back, he said, "Geez, I don't know, everything's normal." you know, what do you think it could be? And I'm like, well, what do I think it could be? How would I know what it is? You know, that type of thing. And of course, obviously I went and I said, you know, my grandmother had Parkinson's, and he said, well, no, you're too young for Parkinson's. So let's not worry about that. And he said, you know, and I'm like, well, it's not getting better. So at that point, he sent me to a neurologist just to see, you know, what it could be other than Parkinson's. And, you know, went to the neurologist. So again, you know, it took 6 months to get that appointment. So I've already been dealing with this now for 6 months or 7 months, and then 6 months to get an appointment with the neurologist after all these other tests that I had to go through. When I went to see the neurologist, when I went through my symptoms and whatnot, at what point, at that point in time, asked me again, you know, what do you think? And I said, I don't know what to think. You know, done my research, and I'm thinking, you know, seems sort of like Parkinson's, you know, some of the symptoms I'm dealing with. And at that point, he basically told me that it was that I was too young to have Parkinson's, that I probably had seen Michael J. Fox on TV, and he is an anomaly, and that I should get that out of my head because it's definitely not Parkinson's. And I asked him what it was, and he said he wasn't sure. So sent me on my way, basically. So went back home thinking, geez, I don't know what it is. And not like I wanted to have Parkinson's, but there has to be a reason or something going on with my tremors and the stiffness and whatnot. 6 months went by, went back to my GP, asked me how it went with my neurologist appointment, which I told him again that, you know, he doesn't think it's Parkinson's, which he agreed, said, no, you're right, I don't think so either. And I said, okay, but I need to find something out because I'm still shaking and I don't know what this is. And he said, well, okay, well, we'll try another one. At which point, finally, he sent me to, actually, let me back up. At which point I had said, well, maybe this time, maybe I could go to like a movement disorder clinic or something, a neurologist or something. So I'd read on the internet. And he said, okay, well, we'll send you in Winnipeg to a movement clinic. 6 months waiting for that appointment. So, you know, we're talking 2 years in, and I'm still, you know, going through all these symptoms, having no relief, and questioning, wondering what this is, what could it be, and basically being told that it's in my head. So I'm kind of worried about myself too, you know, mentally. Is there something wrong with me there? Finally, thank goodness, you know, going to the Dear Law Center and Dr. Hobson and finally being diagnosed, which at the time of the diagnosis, you know, was an interesting phenomenon for me, because when I was first told, yeah, this is Parkinson's, I was almost relieved in a way, because it was something. Now, at least it was something. Now I knew there was something I could deal with, and something I could look forward to. The reality in my situation, and what I'm finding as I talk to many people across Canada and the United States, is that it's a similar story. There was many doctor's appointments, many tests, many things that they had to go through, that because the reality is, it was sort of, it can't be this, it can't be Parkinson's, so let's just try to find out what it could be instead. One of the things that I find very interesting in that is, you know, with the symptoms that I had, the tremor, you know, a resting tremor, you know, the stiffness, telltale signs, you know, my thought is that we need to ensure that our GPs and our doctor and our healthcare are aligned to the point where they know, they're educated a bit more on what it could be, and also that, and no offense to anybody, but it's just not an older person's disease, and that it does happen to younger people, and that it is prevalent, and it is growing, and it is out there, and we have to be able to educate them so they can at least see that, and then on top of that, educate them on where they should send somebody or where they can be, and rather than trying to eliminate all these things, you know, to try to wake your way up there, like, if you have the symptoms that are lining up, why don't we go straight to the source and eliminate Parkinson's first, and then work our way down rather than work our way up? And that's my theory on that. And that's what, just with diagnosis. I have a kind of a unique situation, I think, a little bit after diagnosis, because my GP passed away. So I had to get a new GP, at which point it was very interesting, because I would go in for my regular doctor's appointments, and whenever I would ask questions, or, you know, he'd say, how are you doing? And I'd say, well, you know, I'm kind of have this is going on with me, but I'm not sure if it's just old age or Parkinson's, or you know, I'm not quite sure where that lines up. And his response always, well, ask your neurologist about that. I don't know, you know, ask your neurologist. Okay, fine, I'll do that. You know, and then about 6 months later, he actually quit. He stopped practicing medicine. So I had to find another GP, at which point I had to go in and tell my whole story again. And every time I told the story, they kind of look at me like, "Are you sure? Like, did you get a second opinion? You're too young for this." So there was definitely a miss-hit in information. As you go through that, his response to me at that point too was, every time I asked him a question, it'd be like, "Well, talk to your neurologist, and which then at that point really comes back to me of just me being self-diagnosed myself and trying to educate myself and looking through and Googling and internet searches and everything else. So the reality is that the doctors, this allied health system, the doctors, the GPs need to have more updated information. I think a lot of the information that they're going on is outdated, and it is still in their minds an old person's disease, and it still has, it'll look just like this. And getting a diagnosis of Parkinson's disease is, as I say earlier, it's not a death sentence, but the sooner you get diagnosed, the sooner that you can stop questioning yourself and wondering if you're, what you're going through. And the reality is, after diagnosis, there's a huge life change, not just for you, but for your family and for everybody involved. For me, getting at a young age, I was, halfway through my career. So there were so many questions, what's going to happen to me? Am I going to be able to keep working? And, what is this going to be? If I could have at least found that out 2 years earlier, I had two years of wasted time to adjust to my new reality and to fit Parkinson's into my life and be able to readjust what I needed to do. So the reality is, we need to ensure that not only the public is educated with Parkinson's, but our medical system is educated, and that they're talking together, and they know the resources that are available to them. Parkinson's Canada has numerous immeasurable resources that are available, and I would hasten to say that many health professionals don't know or haven't checked into it. So that's my story. Everybody has a story, and everybody's story is unique. But the reality is, with this disease and what we're dealing with, the quicker we can get information, the quicker we can get diagnosed, and the quicker we can understand what is happening to us and we can evolve, the better that we will be. The easier it is emotionally, the easier it is mentally, the easier it is on our life. And that is my story.
Thank you so much, Bryce. Thank you for sharing your story, and know that it's not unique. We did hear similar stories to Bryce's across the country when throughout the Roundtable series, and outside from just feedback and stories that we hear from the community every day. There's a tremendous amount of dialogue around the importance of a team approach in Parkinson's. So providing training within healthcare education systems to support family physicians and allied healthcare professionals in managing the wide range of symptoms in Parkinson's will really have a significant impact on the quality of care for people living with Parkinson's. So thanks again, Bryce, for sharing your story. I'd now like to introduce my colleague, Christian Valencourt, to welcome our next panel of speakers.
Hello, as Meda said, my name is Christiane Vaillancourt, and I'm the lead for Government Relations and Atlantic Partnerships, and I'm based in St. John, New Brunswick. So another consistent thread throughout our Roundtable series was the need for care coordination and patient education in Parkinson's healthcare. During the Roundtable, we heard a variety of approaches from different regions in Canada on how to address concerns about care coordination and patient education. And we realized that while some communities and organizations are creatively filling the gap in their own ways, this need for care coordination and patient education is universal and warrants consistent solution. We've assembled a panel to provide insight into this issue. First, we have Marlene Lefeve. Marlene works for the Canadian Armed Forces Health Services in Ottawa. And prior to joining the public service, Marlene spent 25 years with the Department of National Defense. She started her military career as a logistics officer in finance in 1995, then transferred to the regular forces to become a health services administrator. During her time with the military, she completed a master's degree in healthcare administration from the University of Toronto and an MBA from the Royal Military College. Marlene is a Parkinson's care partner and has helped her father navigate the Parkinson's journey for more than 10 years. She'll be giving her remarks in French. Just a reminder for all of you who don't speak French to choose your language. Alors, bonjour Marlene. Pouvez-vous
So hi, Marlene. Can you talk about your experience with the coordination of care for your father? Yes, of course. Yes, I prepared a short text. I hope it's going to answer your question appropriately. And for starters, of course, it's a unique case, as we were saying throughout this presentation. My father received his diagnosis 10 years ago, approximately. When he did receive the diagnosis, we didn't have any treatment that was specific or that needed to be coordinated, because the medication resolved a lot of problems. So it was rather management of his drugs that we had to do, and he had some appointments with the social worker and physiotherapy, but there was nothing major at the time. Everything was easily manageable. The recommendation from the neurologist at the time was, take advantage of your honeymoon. You have another good 10 years to live life. That's what my father did, and he lived his life to the fullest, engaged in activities he could do with his health level. Now, we faced problems because we were lacking information and lacking coordination with a recent issue when the honeymoon started reaching its end. So near the beginning of the summer, the end of the end of February of last year, that's when we realized that managing his drugs was not sufficient anymore. My father was had to see the neurologist more and more. He needed more and more help. And with the pandemic, things were more complicated. The coordination need and to obtain more information only came about near the end of the honeymoon, what we call the honeymoon, after the period of time where the disease and the symptoms of my father were under control through medication and through physiotherapy and with the social worker. So lately, the symptoms became more difficult to control with medication. He had a lot of off moments. I don't know how to say that in French, but I think it's a universal terminology. With Parkinson, we say on and off. So he was off more and more, and we were not expecting this to happen, but he had more and more cognitive problems. So we were not expecting that at all. So we were not prepared to cater to his needs and to adapt the care to his needs, to make sure that my father was taken care of according to these needs. So what we were realizing during that period of time, is that we didn't understand his new behavior and his having a hard time having on moments. He was more often than not off. So we had focused until that point on medication management. So we were always waiting for the next the next appointment to get his doses adjusted. That's all we had done so far. But we didn't see much improvement in his status. So what we had hoped for was the neurologist had started talking about the possibility of stabilizing this situation with the duodopa. So we looked for information about that. It was new for us, but we managed to obtain the appropriate information. So we were ready, and we were still oriented on this solution, which was duodopa. However, while we were waiting for the appointment so that we could meet with specialists, with the situation duodopa got worse and worse. My father needed more and more assistance at home. His off periods were longer and longer. And with the pandemic, it was difficult to have a service or to observe that my parents needed so much help because, of course, it's difficult for some generations to ask for help. So that was the case for my parents. So we realized that we had to listen to the neurologist who said during the summer, if the situation does not improve, you need to go to the emergency room to get him admitted to the hospital so that we can ensure a better follow-up and better observation, a more direct observation of your father so that we can adjust the treatment accordingly. So there was a point this summer where we had no choice. We had to go to the emergency. And even though we had managed to obtain help from the health clinic, so we call that CLSC in Quebec. It's a local community health center. Can you hear me? I see messages in the chat and I want to make sure that you can hear me. No, it's all good. We can hear you well. Yes. So we managed to have services from the health clinic. We had the public health clinic. One person was assigned to assess my parents' needs at their home. So quickly, we had excellent service. There was a physiotherapist that came to their home to assess my parents' apartment. She proposed and installed physical adaptation measures. For example, bars near the bed, things to help him walk. The only problem is that it was not adapted to my father's needs. It's not that he needed these support measures. He could not remain in the same spot for more than 15 minutes. He had to change positions and locations all the time. That is what required a lot of energy from us, and it made my mother completely exhausted. And my brother and I went to their home to spend nights to allow her to rest sometimes. So once again, we got to a point where we didn't know what to do anymore to make sure that my father was comfortable in his situation. We requested additional help to the local public health clinic. They have a wide range of programs that they're offering, and it was quite an encouragement. It was quite positive. So the problem was that it had to be my mother or us who would find the stakeholders who would come and help my father at home. We had to look for these people. So for those of you who know the situation, you know that my mother was managing the medication. She was coordinating the care with specialists, with whether it was appointments with the doctor, the neurologist, with the physiotherapist. She was coordinating all of that. And on top of all that management, we were adding on top of that the coordination of other caregivers so that they could come at home and help them. That was too much management on our part. So we had no choice but to use this option and go to the hospital, the emergency, to make sure my father could get adapted care. We weren't able to support my father in an appropriate manner anymore. Every 15 minutes, we had to do something. So every 15 minutes, he had to change positions or move or other things. So all of that to say that once we got to the hospital, that's where we realized that we were lacking so much information about the Parkinson's disease in its advanced stages. We were not expecting that at all. We were not expecting to have cognitive problems from my father's side. We had not researched that because until that point, we had no idea how to react to some situations. And we didn't find any information that was useful. A lot of studies had been done, but it was general information, providing general details about dementia and other things, but nothing specific that could comfort us. The only thing that I found was a YouTube video of a woman in California that was explaining the situation with her stories of hallucinations and that type of problems. So we realized, okay, it's not completely unknown. We're not the only ones living through this. So that was reassuring. But to see something so specific in our province, we had a hard time finding such information and finding similar cases in the province. And what I forgot to say about the local public health clinic, when we got help at home overnight, these caregivers were not aware of Parkinson's disease. They didn't know the disease and its implications. It was difficult. We had to educate them at the same time. And these professional caregivers didn't understand that my father had to have his medication at a specific moment every hour. It was frustrating for us because the health professionals didn't really care about these fine details of my father's management. So it was difficult to navigate through this type of service, trying to obtain information, trying to give information. So in summary, having had someone who was specialized in Parkinson, who could have coordinated the care, would have helped us quite a bit. Having a care coordinator would have been good. And I'm in one of the roundtables, I said that in the armed forces, we have what we call case managers, and when we have complex cases that coordinate with the patient all of the care that they need. They help them go through all of the networks, making phone calls, making sure they have the information they need, because there is a lot of information throughout various organizations, for example, the local health clinic or Parkinson Canada, Parkinson Quebec, but finding what is adequate to your case, to your situation is difficult. At this stage, the advanced stage of the disease, when you find simply yoga exercise, it's not enough. And you're losing faith sometimes because you're lacking this information. Thank you very much, Marlene, for sharing your story.
Thank you for sharing it with us. I'd like to welcome our next speaker, who's Carrie Lynn Goods. So she's familiar to some of you. She's been with Parkinson Canada for nearly 3 years, and she began working with the community development team in January 2019, and then transitioned to the role of information and referral associate in September 2020. Prior to joining Parkinson Canada, Carrie Lynn worked for the YMCA and the Heart and Stroke Foundation in Brandon, where she is based. Carrie Lynn's going to share what the information and referral team does at Parkinson Canada and what sorts of roles the team fills in the Parkinson's community. Welcome, Carrie Lynn.
Hi, thanks for having me. Thanks very much, Christiane. As you'd indicated, I'm an information and referral associate, and I have been doing that since September of 2020. My previous role as a community development coordinator, I think, provided me with the opportunity and a range of experience and reference to transition into this role, supporting previously in the community, facilitating support groups for care partners and people living with Parkinson's, as well as working with community groups and organizations and volunteers. Inr Associates are located regionally in Canada. We triage and receive phone calls, emails, online inquiries from across Canada, and even some international inquiries. French bilingual service is something that we can provide and is available. To give you a concept, around 5,500 requests were completed in 2020. So Inr, Information Referral Associates, provide education on things such as symptoms, medications, allied healthcare professionals, exercise, Parkinson-specific info. We also provide emotional support to people living with Parkinson's, their families, and care partners. We try to direct people to resources that are supportive to them. and we try to keep apprised, so Parkinson Canada resources and supports, and we try to keep apprised of local resources and opportunities that are specific to the Parkinson's community. So having familiarity with healthcare professionals, movement disorder clinics and specialists, supports and programs like exercise groups and programs that are supportive in that way, as well as other Parkinson's organizations. We help navigate their Parkinson's journey, people with Parkinson's, care partners, and healthcare professionals. Receiving a chronic neurodegenerative disease diagnosis is a lot for people to process. We find that many are shocked, surprised, and overwhelmed when they call or contact us, and others are relieved to finally have a diagnosis. Our calls often require compassion. Many callers have tears, heavy emotions, a feeling of desperation, which results in a lot of dialogue and some really long calls sometimes. We commonly have really personal, intimate conversations about things like symptoms, concerns, and experiences, as well as many, as you have already referenced previous to me or prior to me, that many seem to be lacking care and in-person support and support, pardon me. We have difficult conversations, commonly mortality, end of life conversations, emotional things like how to talk with your family and friends about your Parkinson's diagnosis. As a group, we have anecdotally noticed an increase in this feeling of desperation since the start of COVID. Parkinson's disease, I think, can be an isolating disease to start with, and now we've actually compounded the actual isolation, restrictions on social outings, physical activity, and travel. We have had to direct people to crisis lines and professional services with specific training and skills and training for suicide ideation and self-harm. Questions and calls that we receive are broad and diverse. They have included seeking specific Parkinson's information and support, symptom inquiry, where to find a doctor, a neurologist, a movement disorder specialist, other allied healthcare professionals, looking for specific programs, support group connections, housing information, financial information, equipment and assistive devices info, tax credit info, driving concerns, funding inquiries, and employment questions. It's never dull. Some of the limitations of Inr Services, though, are we aren't trained medical professionals. So we can't access anyone's medical records. We don't offer any medical guidance in that level. We provide a very high level of info and resources. And the reality is the current Inr staff are 3 part-time employees. We can't address unrelated other health conditions. People with Parkinson's may have other considerations, and we're sometimes asked how one may affect the other. It's not uncommon for us to say that we need to remember that people with Parkinson's are more than their Parkinson's and may have other health considerations and conditions going on. We cannot make direct referrals to other healthcare professionals, but we do try to let people know of some of their options and to share any information that we may have to make a connection for them. I repeatedly say that we don't necessarily have the answers, but we strive to connect people in the Parkinson's community with those resources that may have those answers for them. I call it connecting the dots. Movement disorder specialists, movement disorder clinics, healthcare professionals, support groups, other agencies, community supports, governmental agencies, research, other charitable organizations, virtual options are available, hard materials. We commonly provide things like tips, about the importance of maybe keeping track of your symptoms and a daily journal or diary to keep those things all in one place. The importance of taking your prescriptions on time every time. Supporting the Parkinson's community. I commonly say it's about putting tools in people's toolboxes or to help them find those that can. It provides people the opportunity to take control of some of the things when many of the things are out of their control. Sometimes people just need direction on where to go for help, and we're that one-stop shop connector, or try to be. That's our goal. Present trends that we are seeing, adult children are getting involved in care coordination at a distance or from a distance, pardon me. So connecting them with resources to support their family members living with PD, as well as care partners, info and resources, commonly in different communities, provinces, and in some cases, countries. Prior to 2020 and COVID-19, there were already access concerns and wait times for many, as we've heard earlier, and that's only been compounded in many or most fields now. Many people in different provinces are still only having some telephone appointments and no in-person doctor appointments. This is compounded by things such as retirements. We're seeing leaves of absence and lack of access to neurologists, movement disorder specialists, or at best, very long wait times. Again, we try to be those connectors to those sorts of resources and information. Now, I think Kelly's speaking.
Thank you very much, Carrie, Lynn. Thank you to everything you do and what the team does. So it's my pleasure to introduce our final panelist for this topic, Kelly Williams. Kelly's the clinical resource nurse at Deer Lodge Center, the movement disorder clinic in Winnipeg. She graduated from the University of Manitoba, Faculty of Nursing in 2002, and then earned her Canadian Nursing Association certification in gerontology in 2005. After working in a hospital for 10 years, she joined the team at the MDC in 2012, supporting people living with Parkinson's. So Kelly, can you please tell us about your role as clinical resource nurse and specifically how you support care coordination and education for your patients?
Thank you. Hi. So my role here at the Movement Disorder Clinic is pretty varied, but the main component of it is care coordination. We do have a full multidisciplinary team that is specialized in Parkinson's disease. So we have our 4 neurologists, myself as the nurse, we have a physiotherapist, occupational therapist, speech language pathologist, social worker, dietitian, DBS clinician. We have a full team, and my role is that when you are needing something more, if you're struggling with anything, you come to me and I'll direct you to whom it is that would best suit your situation. I also will help organize some things out in the community, such as home care or different things with family physicians or things such as that. A big role of mine also is within education. I educate patients on their situation, on their diagnosis, on how to live a good quality of life for as long as possible. I also educate not just in early stages, and we talk about all the good, the bad, and the ugly of it all. I also talk about late stages. We also talk about what is needed as we kind of go on and education needs as they come around. I also do a lot of education opportunities for healthcare professionals throughout the province in Manitoba. I do my best to try and hit as many personal care homes to let them know how to deal with it, home care services, different hospitals to try and get the care that people need when they need it. Education is a big component of what I generally do. But that coordination is really quite important in the sense of trying to get everybody what they need. So, but a lot of what I do is honestly trying to help out. I also have the opportunity to be able to help any person who is also not necessarily a part of the clinic. So I can, if you are not a part of the clinic, you don't have access to our allied health services, but I can help you still learn about it, still get the access you need out in the community. We do have our early Parkinson course that is available to anybody, whether they are a part of the clinic or not. And now that it is virtual, we also are allowing to people who are more rural as well. So I do a lot of different things. Go ahead, Christiane. I see you popping up every now and again.
No, sorry. I thought you were finished. Go ahead.
No, it's just a lot of what I do is trying to find the correct information and the correct people for all of the people who need the help, whether they're a part of the clinic or not.
Well, I think it's obviously we need to clone you or all across the country. So I'd like to thank you very much for joining us and our other panelists for sharing your experiences on this subject. As we heard, there are lots of ways people living with Parkinson's and their families are coordinating care and learning about their condition across the country. And as Kelly shared with us, the opportunity to provide a consistent solution across Canada for the challenges faced by people living with Parkinson's upon diagnosis and throughout their Parkinson's journey. Thanks.
Thank you so much to the panel and to Christiane. Thank you. So as mentioned earlier, another identified theme from the roundtables was the need for more movement disorder specialists in Canada. So currently there is roughly one movement disorder specialist for every 1,500 people living with Parkinson's in Canada. With 50 new diagnoses of Parkinson's per day predicted within 10 years, Canada is going to require an influx of Parkinson's trained specialists to meet this demand. So here to speak to us about some of the challenges that are unique to treating people with Parkinson's in Canada and thoughts on possible solutions and opportunities is Dr. Emily Swinkin. Dr. Swinkin is a neurologist specializing in movement disorder and neurodegenerative diseases. She is an assistant professor in the departments of medicine, neurology, and psychiatry at the University of Toronto. She works jointly at the Movement Disorder Clinic at Toronto Western Hospital and in the Neuropsychiatry Clinic at the Centre for Addiction and Mental Health. Dr. Swinkin obtained her medical degree from Queen's University before completing residency and subsequent movement disorder fellowship training at the University of Toronto. Her clinical research interests lie in optimizing symptom management and improving end-of-life care in people with Parkinson's disease. She is also actively involved in medical education and enjoys teaching medical students and residents about Parkinson's. Welcome, Dr. Swinkin, and over to you.
Thanks so much for that introduction, Amanda. So I have prepared some slides that I'm just going to share now. That's because I tend to find that sometimes pictures worth 1,000 words, and some of the concepts that I wanted to talk about today, I think are better if you can see them than just hearing me speak about them. So just to say, I don't have any financial disclosures apart from recognizing with gratitude that Parkinson Canada did help fund my fellowship. I wanted to start with this quote from a Canadian physician, William Osler, and he says that the good physician treats the disease, the great physician treats the patient who has the disease. And I think that really when it comes to Parkinson's disease, there's no other approach than to know the patient and to treat the patient in front of you. And I think that's really the guiding principle when it comes to the training of movement disorder specialists who are going to be seeing patients with Parkinson's disease. And part of that is because I think that we're recognizing more and more that Parkinson's disease is not a single disease. We're recognizing increasingly that variable genetic factors, as well as environmental factors, coalesce to create multiple different types of presentations, different clinical phenotypes, as you will. And this is just a diagram to illustrate that from a recent paper, demonstrating that we certainly see here on the bottom that there are patients presenting with sort of the typical features of Parkinson's disease, later onset rest tremor, rigidity, slowness, but then you also see patients presenting with mainly only tremor, perhaps no tremor at all. Maybe they present initially with cramping and dystonia and pain. Maybe they present with a lot of neuropsychiatric symptoms, anxiety and depression. And again, we can think about this condition, Parkinson's disease, but really there's a lot of nuance in between it. So I think first and foremost, we need to understand the patient in front of us, because there's no one such thing as Parkinson's disease, if I could be so bold as to make that assertion. Stemming from that is the fact that when we think about the symptoms of Parkinson's disease, they're as broad and manifold as you can imagine, and as I'm sure you've experienced in some of what we've heard from the chats, there's a huge variety of motor symptoms as well as the non-motor symptoms. And really, as a movement disorder specialist who sees patients with Parkinson's disease, my job is to go through all of the symptoms to really understand how a patient is being affected. And then I think it's important not just to stop at sort of a symptom inventory that perhaps we could even have as a bit of a checklist in the clinic, but to really understand the individual in front of us and say, what are the symptoms that matter most to you? And I know that some of my younger patients or patients with, say, public-facing jobs are very concerned about outward motor manifestations like tremor and dyskinesias. And they tell me that it's really important that we control those symptoms. And so it's really important as a movement disorder specialist to understand the patient and which symptoms are having the largest impact on their life at that stage of their disease. So the task for movement disorder clinicians is really, I think, at the core, to understand each patient, not as just a person with Parkinson's disease, but as an individual, and understand how their Parkinson's disease is affecting them. I see myself as an expert in movement disorders and Parkinson's disease, but each of my patients is the expert in their disease. And so we need to work collaboratively in that respect. And then from that, the goal should really be to treat symptoms and optimize supports for patients to enhance the quality of life at every stage of the disease. So what are the challenges that come from that approach? Well, the first, in my mind, is time. There's never enough time in the clinic. And just to give you a sense, so I work in the movement disorder clinic at Toronto Western Hospital. And when I see a new patient for a new consultation with Parkinson's disease, I like to allot at least an hour and a half for that first consult, because I think that that's the amount of time that you need to really hear the story, understand the individual, go through a thorough examination, have a discussion about what Parkinson's disease is, start that education, and then come up with a plan. And that takes a lot of time. And then obviously, the door doesn't close there. Parkinson's disease is a lifelong condition. So whenever I see a patient, I need to factor in the follow-up for that patient. And you can sort of imagine, if you do the math, thinking about, an hour and a half for a new patient, say 30 minutes, which probably is not enough for a follow-up, but that's how much time we're given. If you do the math, it's your clinic day becomes very full very quickly. And this results in very long wait times for patients to come into the clinic. And then it's always a struggle as a movement disorder clinician. Should I perhaps space out follow-ups so that I'm seeing patients less frequently, but I can see more patients? And you see there's trade-offs on both ends. So I think the time that needs to go in to each patient encounter to make it meaningful is really important. And that puts strain given the limited number of movement disorder specialists who are available to the growing number of patients with Parkinson's disease in Canada, people with Parkinson's disease. Another challenge that has been touched on is geography when it comes to coordination of care. And on the right side, this is just a screen grab of upcoming programs for patients with Parkinson's disease in Canada. And on the bottom here on the left, this is a relatively old map, although it hasn't changed that much, where every red dot indicates where a movement disorder specialist works. And as you can see, there are large swaths of the country that are devoid of movement disorder specialists, and that the care is really concentrated around large urban areas. And there are many areas without easy access to movement disorder specialists. And this means that patients living far from these centers need to travel long distances, which is obviously not ideal in terms of from the patient's perspective, but it then also becomes challenging for the movement disorder specialists. For example, in my clinic in Toronto, I see lots of patients coming in from the north. And if I want to, say, arrange for resources close to their home, say in Sudbury, I'm not familiar with the practitioners there. So it really leads to some challenges in terms of optimizing care locally from a distance. The other challenge is really managing the non-motor symptoms in Parkinson's disease. Now, I think as movement disorder specialists, we're certainly aware of the movement symptoms, tremor, stiffness, slowness, freezing of gait, dyskinesias, and also the non-motor symptoms. So the sleep changes that can occur, pain, changes in vision, weight loss, and difficulties with swallowing. Also the autonomic symptoms, so drops in blood pressure, orthostatic hypotension when changing positions, gastrointestinal changes, changes in terms of bladder function, and also all of the neuropsychiatric symptoms, depression, anxiety, cognitive impairment, and hallucinations. And I think probably as a profession, we do a better job of addressing the movement symptoms because those are easier for us to appreciate in clinic. And I think we tend to focus a little bit more on that because those are also the symptoms that respond best to the dopamine replacement therapies that we use most. That being said, we're trained to manage all of the symptoms of Parkinson's disease, but certainly when it comes to other issues, especially relating to, say, bowel and bladder function or psychiatric issues, we do need to rely on other colleagues who have specialty in that area. And this then comes back to thinking about care in a more global sense and coordinating care between specialists. And again, this becomes very challenging when we're trying to do this remotely from sort of concentrated centers. Another challenge is that we don't have a diagnostic test when it comes to Parkinson's disease. It's still a clinical diagnosis, and it can be very frustrating for both doctors and especially for people presenting with symptoms to have that uncertainty before a diagnosis can be made. Additionally, we don't have any treatments that will stop or slow the progression of Parkinson's disease. And this is certainly a very active area of interest, but one of the challenges that we're facing when it comes to treating people with Parkinson's disease. So what are the solutions for some of these problems? I think we can sort of divide it into three ideas. One would be training and recruiting more movement disorder specialists. But I don't think that that's enough. I think, like we've heard from the previous panelists, that we really need to upskill the existing community practitioners and partners in order to enhance those community-based networks. And then I think we can take that one step further and build on some of the recent advances that actually the COVID-19 pandemic has forced upon us in terms of virtual care. And I just want to go into each of those points in a little bit more detail. So certainly, as you can appreciate, there's a lack of movement disorder specialists, and with long wait times, increasing the number of movement disorder specialists is going to help with reducing wait times and improving overall access to specialized movement disorder care. The other prong to that is when we train specialists in movement disorders, we're also training individuals who are likely to have an interest in movement disorder research. And this is, again, going to enhance and grow the research capacity in Canada for the clinical trials that are involved in looking at developing diagnostic tests and looking at developing disease-modifying therapies. And so that's why I really think that it's important to grow the overall pool of movement disorder practitioners in Canada. But coming back to this map, as you can see, there's a lot of ground to make up. And I think that we have to be realistic in recognizing that it would be impossible to train enough movement disorder specialists to really fully meet the needs of all of the Canadians and their families with Parkinson's disease. And I think that we also have to recognize that many specialists who are being trained in movement disorders are going to gravitate to the established movement disorder clinics. Now, certainly some will also go out into the community, but I think we have to recognize that there are always going to be some limitations when it comes to geography, especially in a country as large as Canada. Which is what brings me to my next point, is that we can't just stop at funding for movement disorder specialists. We really also need to look at increasing the training for the practitioners who are already there. And I love this this image from Bastian Bloom, a paper that he published in The Lancet earlier this year. And I like it because it's this schema for how we should envision the network of care for people with Parkinson's disease. So now the people with Parkinson's disease and their families are at the center of care, as they should be. And here beside them in this inner circle, we have the movement disorder specialists. But just as important in that inner circle are the general practitioners and the community nurse supports. That's going to make up the core of the supports that we need for Parkinson's disease. And so that's why it's really important to be training the general practitioners, nurse practitioners, and general neurologists who are going to be sort of the community contacts for those patients. And then coming out in the outer spheres, we also see that there's a large need for other allied health specialists and medical subspecialists, as I've listed here. And I think it's important to develop networks of these specialists who are trained specifically in Parkinson's disease. And those are going to be, as I would imagine, the drivers of these Parkinson's disease networks that can then grow across the country. Here's another image from a different paper, again by Bastian Blom. And this is actually coming back to a comment that was made about the model that has been developed in the Netherlands for Parkinson's care called ParkinsonNet, that's been running now for over a decade. And what has been conceptualized there, that if I had my dream, would come to Canada, is this home, hub, and spoke model. And how this works, if you see on the schema on the left-hand side of your screen, these are all people with Parkinson's disease and their family. And I think it's really important to recognize that the care and education and empowerment has to happen at that level first. And these people are all going to be supported locally by care managers. So these are people who are specialized in Parkinson's disease. And then we see that there are these hubs and spokes, and this is where we get into the regional and regional to national levels. So again, in this spoke, we're seeing these regional networks, again, comprised of specialists and allied health members like physiotherapists, occupational therapists, speech language pathologists, dietitians, rehabilitation specialists, who are going to be based locally in the community to support these patients. And then right there in the center is the specialized Parkinson's disease center, and that would be the movement disorder clinic, such as that I'm working at. And as you can see here on the right, these individual movement disorder centers can then support multiple spokes, therefore supporting a large number of patients. And I think that this model is really what we should aim for when we're thinking about providing care that is based really in the community, supporting people in the places that they live. And one of the ways that virtual care, I think, can be very helpful for this is that it cuts down the barriers to access, both when it comes to the movement disorder specialists being able to provide support from the hub to the regional levels, but also then to enable more expedient, quick check-ins between, again, the hubs in the movement disorder clinics and the patients in their homes. We can also take this even further when we think about, again, monitoring when it comes to, for example, research and clinical trials being disseminated into the community. So I think that there's a lot of potential, both in terms of this model and using virtual care to our advantage. So in terms of just the next steps, I will admit that I'm quite early in my career, so I see several decades of care in front of me, and I really hope and imagine that things will look much different in several decades than they are now. And I think we need to change the way that we're delivering care because, as has been highlighted, the number of patients and people with Parkinson's disease is only growing over time. And so we need to anticipate the growing care needs. And I think really, one, cultivate these hubs of clinical and research excellence and use those hubs to support people living in the community, always coming back to the person at the heart of it. So with that, thank you very much. This is the picture of Toronto Western where I work and our team pre and during COVID. So thanks so much.
Thank you so much, Dr. Swinkin. So much great information there, and definitely some potential solutions to the challenges that we're facing across Canada. So thank you for sharing that. And a note to the French-speaking participants, Dr. Swinkin's slides will be available in French for review following the webinar as well. So thank you so much. So that concludes the summary of our roundtable series that happened over the past few months. But what are the next steps here? We recognize that this is just the beginning of the work that needs to be done. The roundtable series was really an opportunity for for us to hear from the Parkinson's community and get their direction on advocacy needs to help inform the development of a national advocacy strategy. So really, this was just the first step in this process and will be part of the foundation of our future advocacy efforts. So from the summary today, I'm sure you can imagine the amount of information gleaned from the 9 sessions across the country. And now our job is to translate that information into a strong, clear strategy with some actionable goals that elected officials will want to get behind and support. So the next priority item for us is the National Roundtable report, which will be finalized and circulated, available on our website very soon. And this will be followed by regional reports for each of the sessions that we held. And so from there, we'll be using these reports in addition to other data and stories and feedback that we're continuing to collect to really identify the key issues and recommendations that are very specific to the gaps in Parkinson's care in Canada, and the tactics that we will use to influence change in the current practice, models, and policy that are clearly not serving the Parkinson's community consistently and equitably across the country. So on the government relations side, we know that we need to continue to forge new and better relationships with all levels of government. So on the federal side, this relationship building has already begun with the new government that just came into place. So Parkinson Canada has reached out to the new ministers whose portfolios align with the needs of people living with Parkinson's. And on the provincial side, we're continuing to expand our government relations team. So we will have a lead role in each region. So you've met me today, and you've met my colleague, Christian, who is the lead in Atlantic Canada. So our goal is to have a Parkinson Canada representative in each region that is in tune with the specific challenges and issues that you're facing in your provinces to provide further support. And we've already begun preparing for 2 elections in Ontario and Quebec in 2022, and we'll really be leaning on our volunteer ambassador network at that time in order to help us develop the relationships with the candidates and the eventual elected officials. And speaking of ambassadors, we are revamping the ambassador program with a new strategy and direction and toolkit as well, to make it really easy for these volunteers to feel confident and prepared when they're advocating for Parkinson's in their communities. So this is just the beginning of opportunities to engage and stay connected on this advocacy journey that we're on. We will be actively collecting feedback and stories from you and others to strengthen and add meaning to the strategy, and to continue to work alongside our community partners to capture the valuable insight and ideas that the communities across Canada have to offer as well. So we're coming up to the end of the webinar here, but I do want to answer a few questions. So I am going to flip over to the Q&A here. Okay, so let's see. Will you be having further roundtables? So this is a 2-part. Will you be having further roundtables? So never say never, right? We just finished that large series that we've been talking about today. No immediate plans for further roundtables, but definitely do see the value in them. And what at least I envision is possibly having roundtables around more specific topics as we really start to narrow down the issues that we're going to bring to the forefront in the national advocacy strategy, and possibly having more focused roundtable sessions around those. And so the second part is, are there opportunities for other people to engage and share thoughts and insights? Yes. So as I mentioned, opportunities like this today, I see a really active chat and Q&A box, which is fantastic. There's other plans too. I know on our website, we're looking to add a blog to have the opportunity, or to give the community the opportunity to share their stories there. We have the EPP newsletter. We're always collecting stories there. And also through other opportunities like further webinars and through the ambassador program as well, to continue to just glean more insight and feedback from the community. So thanks for that question. And actually on kind of that same note, what is the status of the ambassador program? So great question. I mentioned that a few moments ago. The ambassador program took a little bit, it was really, listen, during the pandemic, really difficult for these ambassadors, these great volunteers, boots on the ground to get out and meet with their, elected officials in person. And a lot of that, of course, wasn't happening. So we're really looking towards 2022, getting prepared now for things to, start opening back up and opportunities to advocate and on behalf of Parkinson Canada locally. So if you were a former ambassador, keep an eye on your email in December. We're sending out an email and a survey that so you could indicate your support and your preference on staying involved in the program. And if you're just looking to get involved, please email us at advocacy@parkinson.ca, and we'd be happy to add you to the network. I know I saw another comment from Pat that kind of aligns with this as well. Any participants today interested in talking about what they might have learned by being advocates in their own communities from a rural area in Ontario, discovering some roadblocks, maybe advocates need a support group. And it's a great point, Pat. And how we're really envisioning the ambassador program is, not only being advocates on the government relations side, but being advocates for, all Parkinson Canada educations and programs and services, and really getting that awareness out in your local communities, and giving you, the ambassadors, the opportunity to connect with one another and to share these roadblocks and to work on some of these challenges together. So lots of really great plans in place for 2022. So like I said, if you're interested in getting involved, please email us. And if you're previously involved, you'll be getting that email soon. Okay. Let me just double check here. I'm sorry. There's lots of different chat boxes open. How does the PAC communicate with people living with Parkinson's, both to obtain input and to report back on their activities? So Parkinson Advisory Council members, they're from across Canada. They represent a range of experience and demographics. Many of them participate in, all sorts of Parkinson Canada activities, so events and support groups, any opportunity they have to engage with the Parkinson community. And we're really working with that group to increase their capacity to share their stories and insights, including attending various meetings and written communication. So I believe you can reach the PAC directly at PAC, so PAC, @parkinson.ca. All right, I think I could maybe squeeze in another question. Sorry, I'm just looking here. Lots of questions. Okay, let's see. Status of ambassador program, we covered that. I think this one was covered in chat, but just in case you didn't see it, this is an important one. Is there a resources self-serve page on the Parkinson Canada website for people who would prefer to search a database instead of calling the INR team? So yes, definitely. There's resources tab right at the top of the Parkinson.ca website. Articles, publications on exercise and wellness, support groups, webinars, newsletters, podcasts, all sorts of information there. So if it's if that's a good place to start for you, rather than calling into the INR team, do visit the website and hit that resources tab, and you should hopefully find what you're looking for. Do we provide info on the advanced stages of Parkinson's disease? So yes, we do. We have resources on specific symptoms of advanced Parkinson's disease, as well as webinars on the subject. And then the support groups also that were mentioned earlier. And also on top of that, the INR team that can provide that information in both English and French on the advanced stages of Parkinson's disease. And then I think I have time. I'll get to one more here. Will Parkinson Canada be recovering some of the community offices and services that were shut down last year? These community groups are such an asset to people in situations like Marlene's. I know Marlene's story. Thank you for sharing that, and similar sentiments shared by many of the speakers today. Yeah, we acknowledge that there was a need, of course, across the country to halt the in-person meetings. I mean, the safety and the health of the Parkinson community is first and foremost for us. But as we look towards 2022, Parkinson Canada is investing in expanding our programs and services offering across the country to really ensure that there's equitable access and a variety of options for everybody affected by Parkinson's. So I believe that's all the time we have today. It's 4:32, at least on my clock, and I don't want to hold anybody up. Depending on where you are in the country, you may be still in your afternoon, or maybe heading off to grab your dinner shortly. So we will conclude there. If your question wasn't answered, there were a few. I've got a couple windows open. We will be sure to track those and follow up with you, and maybe some of those more specific issues after the webinar. But thank you just so much for joining us today. A really big special thank you to our guest speakers who shared their experience with Parkinson's, be it as a person living with Parkinson's or a person working to improve the lives of those living with Parkinson's. Thank you for being so interested in our Parkinson Canada Advocacy journey and our very exciting plans for 2022, and really look forward to continuing to engage with you and working with you all on this strategy and bringing it forward. So stay well and please enjoy the rest of your day. Thank you so much.